The Nipah scare in India has once again turned the spotlight on one of the world's deadliest viral infections. Rare, unpredictable, and often severe, Nipah is a virus that commands attention every time a case emerges. With no approved vaccines and no specific antiviral treatment, even a handful of infections is enough to trigger concern. So over the next half an hour or so, we break down everything you need to know. What exactly is Nipah, how it spreads, how dangerous can it be, and why health authorities are saying there is no reason to panic just yet. Let's begin in West Bengal, where the young nurse has died now following the complications after the Nipah infection. The 25-year-old was amongst the two nursing staff who had tested positive earlier this year and were later declared recovered. But her health never fully stabilized. She remained critical, also required ventilation support, and eventually suffered a cardiac arrest. Officials say the death cannot be attributed solely to the Nipah virus. However, they do acknowledge the infection significantly worsened her conditions and triggered a chain of complications here. But what exactly is Nipah? Let's dive into that now. It is a zoonotic virus, meaning it spreads from animals to humans and can also pass between two humans, people to people. It's also the natural host inside of a fruit bat, or especially any kind of pteropus species. Early symptoms also look like severe flu, fever, headache, muscle pain, vomiting, cough, sore throat, and also breathing difficulty. In severe cases, Nipah can inflame the brain, causing encephalitis, organ failure, and also life-threatening complications. Transmission usually happens through close contact with infected animals to their bodily fluids, or their bodily fluids there. It can also occur through contaminated food, especially raw date palm sap. Now, human-to-human spread is also possible, particularly in hospitals or caregiving settings where close contact is just unavoidable, which is why we had 2 cases reported in West Bengal, both nurses. And also the diagnosis is done through something called RT-PCR testing. We all know that by now, thanks to COVID, using a throat swab. A nasal swab, or sometimes a blood, urine, or also some other fluids that are used for its testing. Later in the illness, the ELISA tests help detect the antibodies, which seem to be the only way forward. But when it comes to treatment, there is no specific antiviral therapy just yet. Care remains largely supportive, hydration, monitoring, and intensive care when needed, which is why early detection and isolation are critical. Nipah is considered one of the deadliest infections known. Fatality rates range between 40 to 75%. That's very, very high. And nearly 1 in 5 survivors may experience long-term neurological complications as well. The incubation period, well, that is typically between 3 to 14 days, where in some rare cases it may also extend for longer. And despite years of research, no approved vaccine currently exists. But here is the part experts want you to remember. This remains a contained situation, at least so far. So far, only 2 confirmed cases have been reported in India, including 1 linked to the recent deaths, like I said. Contact tracing has not found any wider spread. There is no evidence of community transmission just yet. Nipah spreads, remember, mainly through close contact. It is not primarily airborne like the case of COVID was, which significantly reduces the risk of large-scale outbreaks. But India has faced Nipah before, so we have some learnings there. Let's look at the cases earlier on. In 2001, West Bengal reported 66 cases, 45 of them died. In 2007, again, the state saw about 5 cases, and also all 5 did not survive. In Kerala in 2018, the outbreak recorded 18 cases and 17 deaths. In 2023, Kerala again reported 6 cases and 2 deaths. In 2025, there were 3 cases and 2 deaths that were recorded, and each time rapid contamination and also what really helped in these cases was just containing them that helped from wider spread. So the issue here is to ensure that you detect early and you also isolate them early. Authorities are urging now simple precautions: follow quarantine advice if used, wear masks in high-risk settings, wash your hands frequently, maintain strict hygiene. Also, avoid consuming unwashed fruits. Do not drink raw date palm sap or even toddy. And in affected areas, limit unnecessary movement. Nipah, remember, is serious. Its fatality rate, the fatality rate over there is very, very high. But right now, awareness and caution matter far more than panic. So that's everything you need to know about Nipah. But let's deep dive with our expert now on the program to get you more details on this one. Joining me next is Dr. Rajeev. Dr. Rajeev Jayadevan is the epidemiologist, author and co-chairman of the National IMA COVID Task Force and also the past president of the Indian Medical Association in Cochin. Thank you so much for your time. Dr. Rajeev, my first question is that in West Bengal, we had seen Nipah about 10 years ago. And then there were no cases reported in West Bengal. We largely saw cases in Kerala. This time it's come back in West Bengal, and while we are constantly talking about 2 nurses, it has to come through a human source, right? Somebody infected with Nipah who could not be detected was in that hospital and gave it to the 2 nurses. Are we missing something in surveillance here to ensure and get to that 0 patient, the first patient?
Very good question. Since we've already covered the basics, I'll go directly to answer your question. Did the nurse pick the virus up from another person? It's entirely possible. We do not have a proof of that. But for our viewers, as they would have probably heard, the virus freely circulates in certain types of fruit bats, not all bats. And in areas where bats and human beings coexist, or they live together, or they come into contact directly or indirectly, the virus gets a chance to jump onto man. And as you mentioned, the virus, once it infects man, it can spread to other people. And that is what makes Nipah dangerous, particularly from a community health standpoint. So where the first patient was, and that is really called a primary case, the first case. And commonly, because it is so serious and so severe, the first patient commonly is already dead by the time the outbreak is identified. We talked about the Siliguri outbreak 25 years ago in West Bengal, where a large number of people died, and the diagnosis was made in retrospect to initially suspected to be something else. A very large number of people died, and many of them were in fact relatives or close relatives or people who visited patients and healthcare workers who passed away. So clearly it has the ability to spread within hospitals. And the Siliguri outbreak is also remarkable that it started in one hospital and spread to 3 others, which means that 4 hospitals in total were involved in that outbreak. And with a mortality in the range of 70 to 74%. So back to our question here, yes, it is quite possible that a patient who got the virus from the bat, one way or the other, may have come to the hospital, and the nurse may have looked after the person and may have picked up the virus from that person. So it's entirely possible. We don't have proof of that. So that is the reason why such measures are needed to contain the outbreak.
Yeah, and this is the worrying part, because if the patient, I'm sure, had family, they were in touch as well. So this is why surveillance gets really, really important in these cases. However, WHO was very early in sounding the alarm on this one, and they did go on to ensure that some 175 people were tested after that, over 175 if I'm getting the number correct, and all of them have come clear so far, which is good news. But there's a question that always bugs me, Dr. Rajeev. Why are all these viruses found in Kerala? I have never understood. Is it the climate? Is it better surveillance? How is it that the genesis of all different peculiar viruses, it all comes from Kerala or now West Bengal as well?
There are many reasons for this. First, a patient with Nipah does not come with a label, I have Nipah. Someone's got to discover it. Someone's got to find it. And that requires clinical suspicion, the ability to perform a test, the ability to report and confirm it with the reference laboratory in the country. So Kerala, with its prior experience with several outbreaks, it is able to pick up outbreaks at a very early stage and contain it before it spreads to other people. And the way it's contained is, as you mentioned, the contact list of the person is made, and each of these individuals are screened by questions and isolated if necessary, so that they do not get a chance to spread to other people. And after the period of isolation, as long as they remain healthy, they're free to leave. So that's how outbreaks are contained. So diagnostic acumen is what we call it. I'll put this in perspective. Nipah is one of several causes of what's called encephalitis. Encephalitis is, in plain English, it's brain infection. It's a very serious illness, brain infection. And brain infection is caused by several viruses. And Nipah is one of the rare causes of encephalitis. So not all instances of encephalitis do doctors send all the tests for all the viruses. So for instance, if there's a Nipah outbreak in the region, doctors tend to spend time and effort in identifying Nipah as well. But otherwise, it's futile to test for Nipah for every case of suspected brain infection. So that's really the reason why Kerala in particular has reported Nipah in the past. Second is Kerala is a travel hub, because a lot of people who work outside the state, in the rest of the country, as well as abroad. So whatever infections are from, say, from the Middle East or